welcome to the ACR Bulletin Podcast, the show where we examine the latest trends affecting radiology. I'm your host, Chris Hobson, and today I'm joined by Farouk Dako, MD, MPH. At the University of Pennsylvania, Dr. Dako serves as Assistant Professor of Radiology in the Cardiothoracic Imaging Division of the Perelman School of Medicine. He is also an LDI Senior Fellow within the Leonard Davis Institute of Health Economics at Penn. Dr. Dako, it's a pleasure speaking with you today.
Likewise, Chris. Thank you for having me on your podcast today.
Absolutely. We're so honored that you would come back. We're going to try to maybe touch on some subjects, that we might go into a little more detail on some subjects we actually touched on last time. So thank you for coming back and honoring us with your conversation. And I wanted to note that it looks like you're actually joining us from a conference you're attending overseas in Nigeria today. Is that right?
Correct. Yes. I'm actually, I've been in Nigeria for about 5 days. I'm leaving today, a few hours after this podcast. I came to attend the Association of Radiologists in Nigeria annual conference. I actually had to give a presentation. So it was a hybrid conference, but I felt I could do a better job if I showed up in person. So here I am.
Wow. Really putting your money where your mouth is in terms of global health. That's great. And we'll touch on that today during our conversation. But, and just to remind folks who maybe didn't see our first installment of our conversation, your main areas of interest lie in advancing radiology in underserved areas and radiologic public health informatics. We had a robust conversation, like I mentioned last time, about these concepts. And again, we'll link to that last discussion we had in the show notes of today's podcast episode. But I think when we discuss the concepts of data analytics, for instance, and predictive analytics and how they relate to radiology, maybe the conversation became a little abstract. So, a lot of people are still new to these terms, including myself. So can you please define maybe a little more concretely what these two concepts mean fundamentally before we go any further?
Sure. Yeah. I'm sure everybody has a slightly different view of what it is. To me, it's, data analytics is simply the process of analyzing data to obtain useful information to guide decisions, right? And in radiology, we have imaging data and we have non-imaging data. So we do a lot of data analytics of radiology imaging data for various ends, like research, right? Be it like reviews or original research. But there's also a lot we can do with the non-imaging data. We can analyze it, and first of all, by putting it in a structured format and trying to look for patterns in it, and in order to gain useful information. So that's kind of what it is. And we can talk. I can give a few examples that we use it for, but we all do some degree of data analytics in our departments.
Absolutely. Yeah. And I think implicit in that answer is the fact that radiology really sits at a crossroads of so many different, whether it be, clinicians or specialties, things like that, even, patient interactions that, radiology really is so well suited to kind of be, to kind of rein in all this data. So, but I don't want to put words in your mouth, but I believe that we kind of touched on that last time we talked. Is that a fair statement?
Yeah. Yes. Definitely. Right. Like some examples of data analytics that I think most departments or practices use is sometimes we staff our practices based on the data that we get from how images are utilized in a certain place. Right. If we gather that, the ED, or the ORs order certain studies at certain times, and we need to staff accordingly to reflect that, right? So that's an example of using the non-imaging portions of our studies to gain useful information, right? Mm-hmm. People do research about to learn about disparities in imaging utilization by seeing how, images are ordered amongst different racial groups, for example. So to me, that's all data analytics, which is taking typically unstructured data, structuring it in such a way for it to be able to make to make sense.
Gotcha. Gotcha. Well, and also when we last talked, you made an important and I think interesting point about how, as promising as artificial intelligence is, and it is, it can be seen by some as detrimental. It's kind of a yin and yang there. This is particularly true, as I think you just touched on, with respect to health equity, since access to this kind of technology could prove to be actually very challenging for some, and serve to widen the quality care gap that already exists, not only within the United States but globally. So, as a follow up to your initial thoughts, do you think that AI inherently could also we hear so much about the good of AI. Could it have negative repercussions apart from, bias issues, which, again, we'll link to the last conversation we had in the show notes, because I think you went into, you've spoke very eloquently in the last episode, but apart from things like bias issues, could AI have negative repercussions, especially for those in communities who maybe have fewer resources?
Right. So I think there's definitely certain different issues, potential issues with AI, right? So we've talked about potential biases, right? And there's been a lot that's been published about that, right? AI's ability in itself to intrinsically detect race and what that means, right? And AI basically having outputs that factor on race in a way that we might not want it to, right? But to your point, in addition to that, there are other issues that are, that are not specific to race or bias per se, right? It could be something as simple as having AI in places without enough clinical supervision, right? To really make sure its outputs are supervised and it's been used for the right indication, right? And then there's also not having it, right? So one of the potential bad things about AI could be not having it when everyone else has it, and what that could do to your outcomes, just in terms of keeping up with the current science. So I think the potential issues in AI or of AI are a lot, and we're only uncovering them as we start to do more research and as we start to ask more questions. So really, I just think it's important for everybody to be vigilant as we try to introduce it into different clinical scenarios.
Okay, well, thank you for that succinct answer. And how would you say then that predictive analytics relates to data analytics?
Right. So, we said data analytics is really just, structuring data to make sure it makes sense and inform decisions. I think predictive analytics really is just using the same data to make predictions about future unknowns, So, to say, hey, based on this pattern that we're seeing on Thursdays, we anticipate X, Y, Z, and we can, we can make adjustments or we can create interventions in order to solve a particular problem. Or on a more population level, for example, we can do things like, say, we can combine imaging and non-imaging data, right? So there's a lot of research about using CT scans, for example, to predict like osteoporosis, for example, right? Like low bone marrow density, or things like using chest X-ray to predict future cardiovascular risk using AI that people are doing right now. We can combine that with, let's say, geography. Let's say, where based on the non-imaging data, where these studies are coming from, to say, hey, listen, like we're predicting more cardiovascular disease or osteoporosis or, lung cancer, things like that in people in this particular zip code, right? Like we're seeing more XYZ here. We're predicting that if this doesn't happen, that 3 years from now, there would be X amount of negative outcomes. That's sort of predictive analytics, again, is on a spectrum with data analytics. And we can talk about it on a, on a more granular level. We can talk about it in the hospital, or we can talk about it on a population health level.
Yeah, and I guess part of shoring up those social determinants of health, I guess that involves something else that you're really interested in, which is missed care opportunities. So so I know that you're saying from a health perspective, but even from a purely workflow perspective, is that something else predictive analytics can help with? Is literally
Right.
getting people to the hospital, things like that.
Right. And a lot of people, folks have done studies saying, predictive analytics could like decrease, quote unquote no shows, right? For um, MRI exams, CT exams, right? Which, as you just mentioned, affects the hospital operation, right? But it's also a miscare opportunity for individuals who need care at the time. So yes, predictive analytics could definitely help with that. And more importantly to me is that, if we truly believe in the science, and if we truly believe that there should be no miscare opportunities, we can now intervene in a data-driven way to solve these problems.
That's so interesting. Much more focused and targeted way, it sounds like. So, well,
Right.
and you're there in Nigeria. You've only been there a few days, so maybe this isn't a fair question, but even expanding out, if from your network or people there, have you noticed any health equality issues on your trip? If we want to zoom out on a global level, and if so, how would you compare the global issues you're seeing about or maybe hearing about abroad with what you deal with in your work on a day-to-day basis in the United States?
Right. Yeah, thanks for that question. So I'm actually from Nigeria. I grew up here a little bit, and I've been working in Nigeria and as part of my global health work, mainly through RAD. And I'm the program director for the Nigeria program for RAD. So yes, I think your question is great. And I think there are definitely health equality issues here, right? And even tying that to what we talked about AI, right? So at this conference that I just came from, one of the issues that people passionately raise is that if AI comes to Nigeria, who's going to own it, right? Like how do you like there really aren't policies in place right now to make sure that X, Y, and Z persons can't use the tools, right? These like softwares, right? So we talked about like lack of supervision. They're really concerned about it, right? In a place like this where there's already issues between radiologists and technicians, like radiology techs over like, who has the rights to do certain things, right? They're not strong policies here already governing certain clinical issues. So you throw in AI and, they're extremely concerned that AI in a place like this is going to fall in the hands of people with no medical skills, right? No medical training. And it is only going to make things worse. So that's definitely something that they're concerned about. And the health equity issues that we talk about in America are on a global scale, and arguably even worse in other low and middle income countries where there really isn't a middle class, right? You have the rich who have access to, one, leave the country if they needed to. You have a massive issue of brain drain, right? So because the system isn't working out for a lot of people, and therefore you just have, for example, a lack of physicians. You have other people trying to fill that void, right? So you have people without the right amount of training who are trying to do more than the training should let them do. And there's a concern that with AI, things can really get out of hand over here.
Makes perfect sense. It's good they're thinking about it ahead of time. I mean, that is a positive thing, it sounds like. But it's a fascinating point of discussion. Hopefully you'll come back at some future point and let us know how things are progressing. It'd be interesting to keep tabs on that. Another area I wanted to cover in a little more depth, and I already alluded to it earlier, is Miscare Opportunities. In our previous discussion, and you very eloquently just talked about how predictive analytics plays into that. But in our previous discussion, you mentioned, how there's substantial data to drill down on, in order to figure out the cause behind many miscare opportunities. Like, again, you just touched on. So identifying the problem is one thing, but operationalizing a response is something else. So you've got the data, you've got a way to analyze it, but then operationalizing a response is probably taking it to that next level. So can you please provide, some practical guidance to someone who maybe has identified a need to shore up miscare opportunities, which is probably just about everywhere, where they practice, but also maybe who is finding it challenging to align the right stakeholders to resolve the issue?
Yeah, so I mean, I've been in a few different institutions over the past few years, and one of the issues that I've actually heard come up is actually just access to the data. And I'm sure you've heard this too, Chris. Is some folks like us, you're a radiologist in a practice. Like, how do you get this data? And we've heard from a lot of radiologists that hospital administration, for example, isn't just releasing this data for whatever reason. So I think like that might be one of the biggest initial hurdles, is just getting the right people together who have the right data to say, okay, like what times are patients' appointments being scheduled, who's not showing up, where do they live, right? And information from like surveys. So I think some of it is just restricted by the complexity of healthcare systems. But so I do think the most important thing for us as radiologists, I think, is to be able to show the hospital system sort of the missed cost, the missed opportunity for revenue, really, right? Given that these CT scanners are, somewhat of a fixed cost, right? And I think we can sort of take the lead in saying, hey, this is what a CT scanner can bring to a hospital if it's running like XYZ, right? This is what we're seeing. This is how much we're potentially not making. So I think, emphasizing the financial end of things might have more traction, rather than just saying, hey, this is a good thing to do, right? Because as we know, that doesn't always resonate throughout the hospital system.
Right. Speaking that language that the C-suite speaks, which is like bottom line finance speak, might be one way to start. So that's really good advice. Well, one other, speaking of things we touched on last time during our last conversation, one other point I wanted to revisit was that how you characterize radiology as being data rich, which we've already talked about. And because of this, the field's in a good position to lead a more global approach to healthcare. We've talked about how radiology is really well suited to lead that approach domestically. But if you could zoom out to globally for a minute, can you please spell out how maybe you see that playing out, and maybe even if you have one, give an example from your travels to places like Nigeria who are grappling with this now.
Right. So I really just think radiology is unique in that our data can be accessed through, this worldwide electronic, cloud-based system, right? So I can see how pathology and chest x-rays are presented in Nigeria, right? Because we have a PACS, for example, at one of the hospitals that, as an administrator there, in my role through Radiology, I can log in, right? So I'm giving you an example of, I don't think the same applies to all fields, right? I don't think you can sort of document things in other specialties the same way you can document it in radiology, right? Like we can all see how an ultrasound of, a certain tumor looks like, right, with digital radiology. Now, the problem we're seeing on a global scale is that a lot of these places don't have a good PACS system, right? They don't have a way to really store and archive data, right? They don't have policies that enforce practices to store data for, let's say, 5 years, right? But I think because of these problems, there's an opportunity for radiology to be more interconnected throughout the world by providing, store ways for these places to store images and to be able to retrieve them in a way that's efficient. So because of that, I think radiology is data rich, right? We can easily once we put the work in, create, let's say, a database of how, as an example, lung cancers around the whole world looks like, with just a little bit of effort in building the technology. And I don't think the same thing exists in most other specialties.
I totally understand. So maybe radiology is kind of at the forefront of this right now, and we're just kind of, again, we'll have to have you back and see how all this plays out. If you would be gracious enough to come back and, maybe in a while, just figure out how this is progressing. But, you've done such a good job of characterizing the global nature of this. And again, I'll ask you to scale down to the local, if you will. My last question really, in your opinion, what are some practical steps a radiologist or a practice can take to leverage data that they may have, for sake of argument, say they do have access to the data, how can they leverage that data, and other maybe PHM techniques to reach underserved community members, wherever they practice?
Yeah. So if, let's say, I got the data for my institution to say, what, patients patients who are supposed to get CT scans don't show up on Fridays or on like Mondays or in the morning, right? And we look at it and say, these patients were supposed to be, these patients are supposed to have traveled from this particular zip code or that particular zip code. We can look at sort of geographic information systems or things like that to look at the types of transportation from X to Z, right? And see if there's anything we can do about that. But I think most importantly, we can go to those communities and start to talk to the leaders in those communities to really find out what is going on, right? Like why don't people utilize the healthcare system in a way that we think they should utilize it, right? And we might ultimately realize that it doesn't work for them, and there might be a different approach that we can take, right? So folks have obviously expanded imaging services time, like time that it can be accessed to include like weekends, like evenings. For reasons like this, we can one of the things we've realized from going into the community is that some stuff is just about misunderstanding. Like some folks might just not know things about costs. It could be about that. Some folks might just not understand how to engage with the healthcare system. It's, I'm a physician myself, and I think I engaged with the healthcare system for the first time, like when I recently got my job as an attendant, and I got my insurance card, and I didn't know what to do next. I really was like, okay, so like, what do I do next? Like, how am I supposed to start like using this healthcare system? And I'm not the brightest person, but I'm smart enough to be a doctor, right? So like, if that wasn't clear to me, right, then clearly it's not that clear. So we're realizing that just the process of engaging the healthcare system is cumbersome and for a lot of folks, depending on your level of education, and your level of commitment or belief in the process, it just might be too much, especially if you have other problems that are more proximal. You have other social economic things going on that are really more important than like getting a lung cancer screening study. You're not going to follow through on engaging with the healthcare system. So I really think if you had to ask me, like, where you get your biggest bang for your buck, is really just going out to the community and talking to people, right? Like building that trust, not just a one-time engagement, going in there to do one particular thing, but letting them feel that you're here for the long haul, and having them understand why you care, right? Because they're probably already preconceived notions about why you're there in the first place, and it's probably not good.
That was actually my next question is like, the corollary of that is do they trust you being a doctor? Because I feel like trust, you brought up the keyword trust. And I know you're very persistent. We've talked about this in the past. You continually go back and you go back. And I think just the fact of you being there will probably build trust. But, for people that might get frustrated, I mean, physicians in your position who want to do what you've already done, maybe in your own experience, have you experienced that frustration of, just there being pushback, or maybe people saying, yeah, okay, whatever, and they don't do much about it. And how have you pushed through that to build that trust?
I think, I haven't done a whole lot, to be clear, I don't have a long track record of success in these matters, right? But, I've been involved in a few things, and I think the success really has come from taking time to build rapport, right? Just like success in, a clinical encounter is really taking time, going into a community and not rushing and pushing the agenda, right? And understanding that they are preconceived notions and not just ignoring them and expecting that, and showing up with already frustrated as to why folks are not doing the that you think they're supposed to be doing. So I really think just coming in there with some level of humility is the most important thing, and some persistence, right? So I'll give you an example with like this COVID vaccine initiative that we've been doing at my institution at Penn, right? So we started going to underserved communities, and initially there was a lot of success, right? Because they were targeting the older groups who really wanted to get the vaccine, right? But after a while, once that group got vaccinated and you move to the more hesitant group, you would do these outreach programs and only a couple people would show up, right? So sometimes, there was this one that we had, and it was at a mosque, and nobody signed up. Like nobody signed up to show up. And we had an option for signing up or walk in. And, the question was, well, should we cancel the event? Should we, just not show up either and say, hey, listen, nobody showed up, so we're not going to invest resources into this, endeavor. But I think some folks who are more savvy in public health, thankfully, were involved, and they made the decision that it was important that we go where we said we were going to be. Even if we go there and get one person to sign up, that's an important step in building and letting the community know that, listen, when we say we're going to be somewhere, we're going to be there. And, because we mean what we say, and we care, rather than going we could have canceled that and said, hey, listen, why don't we just go to a different place where we know we're going to get more people,
right?
Probably not these underserved groups, but we can at least get better numbers and say and make it look better. So my point is that there is some value in just showing up, getting comfortable, and letting folks know that you're here.
That's so interesting, because we've talked so much about numbers and data, and then I feel like it's great to end on a more human note. So you're counterintuitively saying we didn't have the numbers, but from a human perspective, just showing up is, what's the old saying, is 95% of the success is just showing up, right? So, well, thank you, Dr. Dako. I thank you so much for taking time out of your obviously very busy schedule to speak with us today. Well,
Yeah.
I also want to say to our listeners, we'll make sure to include that link to our last conversation, as I mentioned before, in the show notes. And please do, if you have any ideas for future show topics, we always welcome them. Please do hit us up on Twitter at Radiology ACR and use that hashtag ACR Bulletin Podcast. I also invite you to check out all of our episodes at Apple Podcasts, Spotify, Google Podcasts, and ACR's YouTube channel. And please do subscribe to get all of our latest episodes. Thank you again, Dr. Dako. We really, really appreciate your time, and please do enjoy your travels.
Awesome, Chris. Nice talking to you as usual.
As usual. Hopefully you'll come back soon. Well, and thanks so much to our listeners. This has been the ACR Bulletin Podcast. See you next time.